Minimal change disease is the topic for this video, and minimal change disease is basically the most common cause of nephrotic syndrome in children. And before I get into minimal change disease, I would like to talk a little bit about nephrotic syndrome, just briefly, so you have an understanding of what's happening. Nephrotic syndrome basically has a few basic components. The first is the person will have proteinuria, protein in the urine, a very, very high amounts. In fact, it's called massive proteinuria. Next, you'll have, as a result, the protein is being lost in the urine, the protein will be low in the bloodstream, so it'll be hypoproteinemia, but I actually put hypoalbuminemia because albumin is the type of protein that we're actually discussing. And the third thing is edema. Now, this happens because there's a pathology in the kidney. So normally protein is not supposed to go out into the urine in large quantities, but if it does, that obviously means there's a pathology in the kidney. This happens directly because of the first thing, protein's being lost, so that means there's less protein in the blood. So why does this happen? This is what I really wanted to explain. Well, I wanted to describe a scenario in which you have a child. You might see this on television when they describe a famine in any part of the world. And you have children with these big swollen bellies. Why? They have no food. Why do they have swollen bellies? Well, this is what's happening in children. If you have no food, the children are malnourished. So because they're malnourished, they have very low protein in their diet. And as a result, they develop edema. Now, the reason they develop edema is because you have, let's say, a blood vessel. Inside the blood vessel, you have protein, normally. In a state of hypoalbuminemia, the protein is absent. It may not be completely absent, but it's much lower. So as a result, the oncotic pressure inside the blood vessel is decreased. Oncotic pressure is basically a pressure that involves proteins, and it tends to pull water into the circular system. That's what oncotic pressure does. When you have low protein levels, the oncotic pressure becomes lower, so the water doesn't come back into the circulation. The water actually leaves the intravascular space and goes into the interstitial space. And when that happens, you get these big swollen bellies resulting and that's what really edema is. And there's other parts of the body that can be swollen as well, like for example around the eyes and the feet, and we'll get into that a little bit later on. So back to minimal change disease, and it's the most common form of nephrotic syndrome in children, and on average the age is about 4 to 8 years of age. And basically the symptomatology is you have a child who has some swelling. It may be a total body swollen known as anasarca, which is generalized edema, or it could be just around the eyes, periorbital edema, or it could be the feet. And initial diagnostic testing will, if you do the urine test, it will clearly show massive proteinuria. And then when you do the blood tests, you will clearly see low albumin levels in the blood. Now, what's the definitive diagnosis? What is the thing that you do that would clinch the diagnosis? And that is the renal biopsy. Now, before I get into the treatment is actually pretty straightforward, but I just want to mention, why is it called minimal change? What is the reason that this disease is called minimal change? The reason is because historically, when they just had light microscopes, when they would try to look at the kidney, they would essentially see normal kidneys. So that's why it's called minimal change. Later on, when they developed electron microscopes, then they were able to spot the pathology, which is basically involves the glomerulus of the kidney. So that's where the minimal change comes from. Alright, so finish off with treatment. Treatment is basically you give steroids, most commonly prednisone. Okay, so let's look at a couple clinical vignettes to see what this looks like in a patient presentation. 20-year-old male with a history of nephrotic syndrome is seen in the clinic after a renal biopsy. He is presented a week ago with anasarca, generalized edema, foamy urine, without hematuria. His blood pressure is 100/60. Examination reveals periorbital edema, clear lungs, normal cardiac exam, 4+ edema and anasarca. 24-hour urine contains 8 grams of protein, and serum creatinine is 0.8. Urine analysis shows 4+ protein, no red cells or casts. His renal biopsy is read as minimal change disease. Which of the following is the most appropriate next step? Well, this question pretty much spells it all out, and they're just asking for the treatment, and steroids is the treatment. So that would be prednisone. Finally, a 3-year-old child develops generalized edema, severe, following a viral infection. On the basis of clinical chemistry tests, a renal biopsy is performed with a normal light microscopic findings. Which of the following abnormal lab values might be expected in this individual? Well, it's a good question. Seems like very limited information. How would you possibly know the answer? Well, here's the key. Remember I discussed that before the invention of the electron microscope, when they would do that testing or the analysis of the kidney, they would find essentially no changes. So that's why it was called minimal change disease. So that's essentially what this question is getting at. And then we all know in minimal change disease, what do we have? Lab values. Well, we have edema, but edema is not a lab value. We have elevated protein in the urine, and we have low protein in the blood. So this would be, the technical terms are hypoproteinemia or hypoalbuminemia, because albumin is the specific kidney we're talking about, and this is just proteinuria. So let's see if one of these is one of the answer choices. Decrease alpha globulin levels, no. Decrease fibrinogen, no. Increase serum calcium, no. Low serum albumin levels, yep, that's the one, hypoalbuminemia.